It's Friday, the 4th of October, and this is the Hot Topics podcast. Welcome to the Hot Topics podcast from NB Medical. Neal Tucker here to see you through the next 20 minutes or so on what's new in the world of research relevant to us in general practice. We're in full swing over at NB Medical HQ this month, so we've got loads of live webinars coming up. So next Friday, the 11th, we've got our new Hot Topics course. I'll be helping run that one along with Kate and Mark. Then we've got our Women's Health course the next day. We've got our Irish orientated Hot Topics course coming up the week after. We've got our primary care cardiology and ECG course coming up at the start of November, and loads more. So do check out the nbmedical.com website for that. Remember that you can see all of them on demand if you can't make the live dates, and check out NB Plus, our subscription service, where you can get access to all of them for just over £300 a year. What's going on in the news? Well, the new news seems to be the old news, more about collective action, GP practices in England taking part in the BMA's recommendations, lots of having signed up, the impact of which is yet to be truly known, and then physician associates still in the headlines with the RCGP voting to oppose a role for them working in general practice, despite the fact that there are already 2,000 of them doing exactly that. Today, I think we'll just get on with the research. And as usual, we've got 3 papers to look at. So one in the BMJ on acute treatments for migraine, one in the New England Journal of Medicine on the role of prostate cancer screening. And then finally, we'll have a look at a paper in the BJGP on first contact physiotherapy appointments in general practice. Okay, let's start with the BMJ paper. So this is titled Comparative Effects of Drug Interventions for the Acute Management of Migraine Episodes in Adults, a Systematic Review and Network Meta-Analysis. This is a subject close to my heart as someone who's had migraines for most of their life, often quite frequent. I know that lots of you out there, because the statistics tell us that around 20 to 25% of the population also get migraines, will have similar issues, and of course that means that loads of our patients do too. So knowing what are the best treatments to recommend them is always going to be really, really helpful. But is this really new news? We've already got national guidelines from NICE and from SIGN that already give us recommendations about what would be the appropriate first line, second line, third line treatments to use for acute migraine management. What's new with this study is it incorporates a very wide range of possible treatments and looks at the efficacy and tolerability of them compared with each other and compared against placebo. Now here's a quiz for you. Play along at home. How many different acute migraine treatments can you name? Well, this paper includes 17 of them. Yeah, 17. Who would have thought that there should be so many, including ones that I'd never heard of before. So elatriptan, maybe I'm behind the curve on here because I looked it up in the BNF and actually it's prescribable in the UK, but there's also ones that aren't. So lasmiditan, never heard of that before. That's actually not got a license in the UK. I think that's one for the States. And then these newer treatments such as romegapant, not ategapant because I think that is too new, but one called ubregapant, which again I don't think is licensed in the UK. The primary outcome of the study was the proportion of patients who were pain-free at 2 hours post-dose and then also sustained pain freedom at 2 to 24 hours. 137 randomized controlled trials were included, almost 90,000 patients. And because of that number of patients and because it's a network meta-analysis, it's allowed the authors to literally vomit graphs and tables all over this paper. Most of them are entirely indecipherable, but they do include the absolute risk of experiencing the outcome, i.e. your absolute risk of being pain-free at 2 hours for each of the treatments. Notable results then. Well, if you want to be pain-free at 2 hours, your best chance is with a triptan. So elatriptan, the one I'd never heard of, that comes out top, with 30% of people being pain-free at 2 hours. Then rizatriptan 33%, zolmitriptan 28%, sumatriptan 29%. Ibuprofen, my personal go-to, came out at 20%, and all of those are better than the new GEPANTs like Remegapant or Ubregapant. It's a slightly different picture if you want to be pain-free at 2 to 24 hours. Then ibuprofen does come out top at 38%, followed by elatriptan at 26%, and the other triptans not far off. Remegapant bringing up the rear of this little group at 16%. Tolerability can be an issue, and I, for one, can't actually take the triptans. They make me feel really weird, this kind of dissociated response, very peculiar, without actually helping the headache at all. The two key adverse effects that they reported on was nausea and drowsiness, and around 13 to 15% of people would have those with a triptan, slightly lower, but not by much, to be fair, with ibuprofen at 11%. Similar responses with the GEPANTs. The authors conclude that overall, elatriptan, rizatriptan, sumatriptan, and zolmitriptan had the best profiles, and they were more efficacious than recently marketed drugs such as lasmetidine, or you know what I mean, or, well, maybe we don't because we don't use it here, Remegapant or Ubrogapant. They do touch on the concept of cost effectiveness, and I think that's an important one to bring up because particularly with the triptans, there is a huge range in price. So sumatriptan, which we'd all currently would prescribe as our first line, is really very cheap, but somehow all the others still seem remarkably expensive. Often several pounds a tablet. Compare that to several pence for ibuprofen. Then there's also the individual response. So triptans don't help me. They give me lots of side effects. Ibuprofen is the only thing that seems to work really, really well for me. There is going to be huge variation between individuals, and we'll need to explore what works for each person. They also didn't explore in this paper combination treatments, which of course is what NICE recommends first line with a triptan plus an NSAID or paracetamol. Having more data on that would be useful, although I do wonder how many of us actually recommend combination therapies to patients when they initially present, or indeed how many patients actually want to take more than one treatment, because let's be honest, most people don't actually like taking tablets that much. Having said that, you know what? If I've got a bad migraine, I would take all the tablets. I suppose whilst we're thinking about it, let's not forget about the non-tablet options too. So that may be a benefit for some people with triptans, for instance, sprays or injections. There are times when your migraine where your stomach just shuts down, it's going to make you want to vomit, and tablets are going absolutely nowhere apart from straight back out. In conclusion, what have we learned from this study? Triptans are pretty good for very short-term pain relief. Ibuprofen is also good for slightly longer-term pain relief, and elatriptan is a thing that exists, although at around 20 to 30 quid for a pack of 6, you're probably not going to be prescribing it anytime soon. Okay, let's move on to our second paper, and we're going to think about whether we should be screening for prostate cancer. Now, this is a difficult question to answer, and I can't promise that we're going to have all the answers by the end of this paper, but it certainly does add a little bit of information to what we already know. We know that sticking your finger up someone's bum, that doesn't really help, but what would help? Now, in the UK, of course, there is no official screening program for prostate cancer, leaving it up to the patient and the clinician to decide between them whether they want to start the process by doing a PSA test. For years, we've been told in the context of screening that PSA is a bad test. It overdiagnoses. It misses important cancers. The literature around this really seems to have sold up on the disadvantages, and I think that's probably skewed clinicians' opinions away from using this test. But technology has changed recently, and with the advent of MRI for prostate cancer, this has continued to change not just the pathways, but also the risk-benefit profile of doing that initial PSA test. Now, despite the fact that we've had MRI scans established as the initial first step in assessment of men with raised PSA throughout the UK for a number of years, what we don't have is any clinical or national consensus on whether we should be now adopting population-based screening. This new paper published in the New England Journal of Medicine last week tries to provide us with a bit more information to inform that decision. So this was a population-based trial. It started in 2015, conducted in Sweden, and they invited men who were 50 to 60 years old to undergo PSA-based screening. And if they had a result of 3 or more, then they were randomized to one of 2 groups. So in the first group, they had systematic biopsy. That's what we've traditionally done for years. You randomly shove a needle around in someone's prostate, gathering a whole bunch of tissue from all over the gland, and then take a look at it under the microscope. MRI has allowed this to be nuanced now, so you can identify specific lesions on an MRI scan and then target them with biopsying, which reduces the rate of infections and therefore morbidity. But also, if you don't see a lesion at all, then you don't have to have a biopsy. All of this sounds great, but what I hadn't appreciated before in this discussion is the limitations of MRI. So MRI can miss lesions. Indeed, this may be an advantage in some situations where the lesions are those very small, those very early, those very indolent cancers that actually you just don't want to know anything about. But there are still questions amongst specialists about whether omitting the biopsy after a negative MRI could miss some, probably a tiny minority, but some cancers that could be clinically significant and delay diagnosis in those men. Now, I realise I've digressed a bit in trying to explain the rationale behind this study, because these patients were randomised to one of 2 groups. That first group, they had a systematic biopsy, but they also had an MRI. And if that identified lesions, they would have targeted biopsies as well. And then the second group was on an MRI-only pathway. So they had an MRI if they had a raised PSA. Then if the MRI was negative, just like in the UK, you would get no biopsy. If it identified a lesion, then you would have a targeted biopsy. There were 2 questions they were trying to answer with this study then. So firstly, could you reduce the rate of overdiagnosis and unnecessary investigations by using the MRI pathway compared to doing systematic prostate biopsies? And secondly, was it safe? So by adopting the former approach, would it lead to a greater rate of missed clinically significant prostate cancers? Now, the primary outcome was the detection of clinically insignificant prostate cancers. You would think that the primary outcome would be the detection of cancers that are actually going to kill you. So why are they looking at it the wrong way round? Well, the reality is that most men, particularly in this age group, if they've got a prostate cancer identified, it's probably going to be a low-grade one. It's going to be one of the indolent ones, which will realistically cause them no problems for the rest of their life. Except, as their editorial points out, when men have a diagnosis of a low-grade prostate cancer, typically they'll go into active surveillance, which is a legitimate and effective management option. But the reality is that lots of men, even when they're having regular follow-up scans that shows their disease hasn't changed at all, they decide to go on and get an operation to remove it, an operation that, strictly speaking, they don't need. So why are men taking this seemingly illogical option? Well, without wanting to trivialize this, I'm going to give you an example involving air fryers. So I suspect many of you get the same as me. Sometimes you get an idea in your head, this kind of niggle that goes on, and you just can't shake it. Recently, I had this about air fryers. I've been thinking about it for months now. It's been killing me. Loads of people I know have air fryers. Everyone seems to love them. I wasn't entirely sure they're any better than just using a fan oven, which I already have. And I know that if I got an air fryer, my wife would be really pissed off at me for buying more gadgets that we just don't have the space to fit into our house. But still, this niggle kept on eating away at me until eventually I've bought an air fryer. But if that's happening to me about air fryers, imagine what I'm going to be like over prostate cancer. So I totally understand why people might ultimately end up having a procedure they don't really need, just so that you can remove that niggle, that constant uncertainty, that fear that at some point in the future, this might get worse and it might do me serious harm. Given then that knowing you have a not dangerous prostate cancer is not enough, the phrases not dangerous and cancer just don't go together very well. Given that knowing that is not enough, the best thing is to never know in the first place. So I guess the real question of this study is, can we miss cancers that are not dangerous whilst avoiding missing those that are? On to the results then. So they showed after a median follow-up of just under 4 years that prostate cancer was detected in 2.8% of the MRI targeted biopsy group versus 4.5% of the systematic biopsy group. To give you a bit of context, each of those groups had just over 6,500 participants, and in the former there was about 200 cancers versus 300 in the latter that were identified. Specifically addressing our key questions, the relative risk of detecting clinically insignificant cancer in the MRI targeted biopsy group was less than half of that compared to the systematic biopsy group. So that sounds really good. That's a very positive result. Less men will go on to be worried about cancer that will never cause them any harm, and indeed may avoid significant operations as a result of that. The good news, however, is tempered a little bit by the results that show that less of the clinically significant disease was identified in that first group compared with the systematic biopsy group. Before we get too bummed out by that, the authors do point out the difference was marginal, and the associated editorial helpfully puts the results into context that we can easily understand. So in absolute terms, per 1,000 men enrolled in the screening program, the MRI targeted biopsy approach led to 51 fewer men undergoing biopsy and 14 fewer men receiving a diagnosis of grade 1 disease. The flip side is that it also led to a delay in the diagnosis of clinically significant disease in 3 out of 1,000 men. To quote the editorial, the meaning of this delay is not immediately clear, but it could potentially lead to worse outcomes in a fraction of those men. What's really interesting about this paper is that it's demonstrating how we continue to push the boundaries of medicine and science. As the authors point out, we really don't even understand the natural course of how prostate cancers look on an MRI scan. So the big question that remains really is whether that tiny proportion of cancers which are missed by an MRI scan and are truly high grade in nature, whether they will be picked up by subsequent screening rounds before they develop metastatic potential. I think this is a really interesting area, ripe for further discussion. And in the next podcast or two, I'm hoping to have an interview with 2 clinicians, one a GP and one a radiologist, both with special interests in prostate cancer, who can maybe shed a little bit more light in this area. In the meantime, we of course don't have a prostate cancer screening program in the UK, but I think this research further gives us confidence to be able to use a PSA in the context of an MRI prostate pathway to help reduce overdiagnosis and overtreatment while minimizing the misses. So our last paper is in this month's BJGP, and this is all about first contact physiotherapy and evaluation of clinical effectiveness and costs. And this feels quite timely with all this discussion around physician associates, with the issues around GP trainees in England struggling to get employment. It's raised a lot of questions around the additional roles reimbursement scheme more generally. A few months ago on the podcast, we we're talking about an American paper which suggested that non-doctor clinicians seeing undifferentiated patients in primary care may actually lead to health service costs being greater overall. But what about first contact physiotherapists? Because this seems like a really sensible thing to do in general practice. As much as I love trying to deal with musculoskeletal problems, and I like to think I'm quite good at them because 21 years ago I did 3 months as a house officer in orthopedics. The reality is, if a patient has a musculoskeletal problem, seeing a physiotherapist who has specifically trained in this area and then has realistically lots of years of experience probably is going to be better at it than I am. In this study, then, they recruited 46 general practices, each of which would follow one of 3 models. So either a GP-led model or a first contact physio, but a physio that wouldn't prescribe or inject, or one of the very extended scope physios who would see people but could prescribe and or inject as well. They followed up 426 adults who took part in this, and they gathered data on them at baseline, 3 and 6 months, with the primary outcome being the SF36 Physical Component Summary Score. This collects data from patients on physical functioning, physical limitations, pain, health perceptions, energy levels, social functioning, emotional issues, and so forth. The researchers, as a secondary outcome, also collected data on general healthcare usage. This was a non-inferiority trial, and they demonstrated no significant differences in physical function across all 3 arms at 6 months. At 3 months, there was a significant difference, so the numbers improving were much better in both of the physio arms compared with the GP-led arm. That would suggest to me that the patients being seen by the physio were getting better just that little bit faster. There were no safety concerns that were raised, and actually following initial consultation, when they looked at patients receiving medication from their complaint, that was much higher, almost double in the GP-led arm, which may include opiate prescribing, compared with both of the physio arms. This first contact physiotherapy approach then seems like a really positive one. But what about the costs? Usually, these practitioners are going to be having longer appointments with the patient than they would do if they came and see the GP. How does that influence the discussion? Well, they did a cost analysis in this paper, and they found that the costs were significantly higher with the GP-led model, so a median of £105 per patient versus around £41 to £44 with the physio. The authors conclude that first contact physiotherapist-led models of care provide safe, clinically effective patient management with cost benefits and reduced opioid use in this cohort. So as much as it pains me to say, because I really do enjoy trying to assess patients with musculoskeletal problems, if I want to do the best by my patient, then a first contact physio probably comes out top. Okay, thanks so much for listening today, everyone. We'll be back in a few weeks' time with more research relevant to us in primary care. Don't forget, you can always get in touch by email, hottopics@nbmedical.com. You can find us on X and Facebook as well. Keep a lookout for those live webinars coming up over the next few weeks. Hopefully, I'll see you on a few of those. And otherwise, look after yourselves. Take care. Bye-bye.